Good evening, and thanks for joining me on this webinar on the important topic of impression making. My name is James Braun. I specialize in prosthodontics in Saginaw, Michigan. I would like to extend my appreciation to 3MSB for the support of this project. Tonight's presentation will reflect the issues we deal with every day as clinicians with the task of taking impressions for crown and bridge cases. The course tonight will touch on the very latest dental materials, equipment, and techniques for securing premier VPS, vinyl polystyrene impressions, as it relates to CAD/CAM dentistry and specifically all ceramic crowns. I've been working on this thing for a number of weeks, trying to assemble a chronology of cases and steps that are important for the successful outcome. After this brief introduction, we'll get into various ancillary equipment, materials that will aid us in the reproduction of wonderful impressions. There's various impression types, various delivery systems. We'll talk about that, talk about how we displace soft tissue for adequate impressions, how we deal with hemorrhaging and things like that. And towards the end, we'll deal with some of the additional equipment, which I feel is very helpful when it comes to taking impressions, such as specifically soft tissue diode lasers, which have really become invaluable to me. And I want to approach this from a standpoint of trying to tie things together. The bulk of this and the focus is to deal with the focus is on impression taking, impression materials, and techniques. But I also want to tie in some of the other very crucial steps which are part of the whole procedure, such as use of specific luting agents, cements, provisionals, and a little bit on articulation, because I think these are all certainly just as important for the final success of the case. But really, the gist of this will be simply to deal with impression materials and impression techniques. I listed here some of the other items and materials, equipment, and procedures that we get involved with when we talk about a case, whether it be a single unit through multi-units through fixed bridge work, that we all have to keep in mind as we proceed on these cases. These equipments that I list here, some of these really are extremely beneficial. We haven't had on board for only in a recent history. Certainly they will aid us in the comprehensive approach to our cases. Things such as the Vita 3D shade system, fiber post for building up post and cores, adhesive luting agents are extremely important, LED curing lights. We're not going to spend a whole lot on that, but just to mention that they are all part of this pot that we mix for the final successful outcome. But I will want to mention a couple things real briefly at the beginning, which I think are intuitive, but at the same time we can't take for granted. The fact that now we have these really lightweight LED headsets. This is a 3x magnification, 3-watt LED, which allows us illumination in the oral environment unlike any other types of equipment that we've had before. These are lightweight, they're easy to pop on and off, and really offer us insight and clarity we haven't had available. And certainly they offer also the orange filter you see here for doing composite dentistry. The other piece of equipment which I think is really lends itself towards precision and accuracy is an electric handpiece. These electric handpieces allow us a consistent torque. They allow decrease in heat production, noise production, increased cutting precision, defined margins. And if you haven't had a chance to utilize these, you really offer a great deal of precision and definition we can't get with our regular air turbines. So if you're at a trade show or you want to demo one of these in your office, you'll find out how beneficial they can be when we talk about margination and delineation, definition. These can really offer a lot to us from that standpoint. But to kind of put this thing in perspective, as clinicians, when we take on these cases, we have certain goals in mind, from starting through preparation, through treatment planning, and where we'd like to end up when the case is completed, the patient leaves the office for that day, and we can feel really satisfied that we've offered premier treatment for our patient. I just want to show this real brief case to kind of give a little insight in where we're going with this particular presentation. What are the goals we strive for when we talk about impression technique? And this was a young lady I did about 7 or 8 years ago, at least the initial placement of the crowns, the porcelain fused metal crowns on 8 and 9. You can see some of the issues that take place when you have porcelain fused metal. You get usually some of the darkening of the soft tissue, the free gingival area, because of the blocking of the light, because of the metal surface there. And the fact we have more of a high value opaque look to these crowns, certainly they're acceptable and they can offer a lot in many instances, but when you talk about trying to match artificial crowns to natural dentition, it's really a daunting task. In this case, a couple years ago, I decided to replace these with all ceramic crowns. So as we undertake this project, we have certain things we want to keep in mind. One is the fact that when we do replace these with our all ceramic crowns, we have the capabilities of illuminating the soft tissue to blend in with the natural dentition, reflection, refraction of that ceramic product in the oral environment, and how it has a tendency to mimic the surrounding dentition and give us something which is really going to blend in inconspicuously with the surrounding teeth. The other thing which really ties into what we're talking about tonight is the absolute impeccable fit of these CAD/CAM or pressed ceramic crowns. We can get the marginal adaptation down within 75 microns or so, which to me is incredible. These are the best fitting restorations I've ever been able to place for a patient, are these types of crowns. And they really offer precision unlike anything else because of the fact that how they're manufactured are capabilities of delivering really precise impressions. Because as we place these, you can see the difference in the soft tissue and how it has a tendency to really hug the glazed porcelain. The emergence profile is so wonderful and so adapted that the patient has easy for home care, and these will last for a very, very long time and look really good as they blend in. But the key to it is also then the outcome. You take a radiograph, you can see the fine margination that's created with these restorations. The opaque layer is the cementing layer, and the transradiolucent area is the ceramic material. But by putting all these facets and features together, we can offer this time and time again to our patients. And that's really what we're going to deal with tonight, is how can we achieve this type of outcome. Now, one of the issues that we have, and I've talked with a couple people in very large labs within the United States, and they cited to me, as it kind of reflects on this particular graph, that the number one reason for remake of crowns is the fit. In other words, the dentist will get a crown back and he'll try to seat it. It doesn't fit all the way. The margins are open. Perhaps there's problems with hyperocclusal contact or it rocks, whatever the case may be. And there's need to then to go back in and remake the impression, remake the crown. And that becomes really an issue. The number two issue being the shading. But issues of poor impression that require remake and fabrication new crowns cost the clinician both time, money, maybe even undermine the confidence of the patient. And successful impression technique can accomplish this time and time again with the use of the equipment and materials we're going to talk about tonight, and something we can utilize on a day-to-day type of basis. And that's what we're going to be getting into here as we press on with this particular presentation. Because there are problems that we run into from a standpoint of having to deal with improper techniques or improper impressions that create issues. A study a few years ago in the JPD cited that over 50% of the impressions that were submitted to the lab had visible defects in the marginal areas that were potentially disastrous, and that can lead to all sorts of issues. Impressions should be free of flaws such as voids and folds and creases and tears and ragged edges around the margins. We need to have very sharp, distinct margins, smooth axial surface, and really paramount to the fabrication of these crowns, especially when you talk about digital scanning of the models by the dental technician for the construction of these very accurate fitted CAD/CAM restorations or press restorations. You can see one of the issues here. We have torn margins, incomplete margination. Perhaps there's a problem of inadequate tissue distension, not getting the material down into the sulcus. Really impossible to go ahead and fabricate an adequate fitting restoration. We have situations here. This is a triple tray. I don't even know how you can get all this material in at once, opposing in the surface you're trying to go ahead and impression. But you can see we have problems here with the burn through, right in through here in different areas. That can create all sorts of problems of disparity and discrepancy. The margins not even well formed. It can really lead to a massive failure when it comes to trying to get this into place and have good marginal adaptation. We have to be alert to that. We talk about larger cases and what's the best way to go ahead and fabricate these restorations. We also have problems with torn margins, maybe tear strength, maybe inability to go ahead and get the material subsulcular. We get relapse and collapse of the sulcular tissues. It becomes a real problem. It can pinch off the material, or we may have fluid or blood subgingival, which create problems of improper polymerization. That can become a problem down the road. We also have to be mindful of the fact triple tray can be an issue. One study pointed the fact that more remakes were created when the clinicians used triple tray. If it is used, I think that you can use it for a single crown at most. There are things that you have to kind of keep in mind. One is, if you are going to use triple tray, make sure you use a metal tray. Plastic trays have a tendency to deform more, create enlarged dies, and that can be a real problem when it comes to accurate fitting restorations. The other thing, the patient has to remain in the proper centric occlusion for up to maybe 3 minutes. You have to think about where the saliva is, where the tongue is, the cheek muscles, because we can't evacuate the area very effectively. And then we have to think also about is, you know, what is it going to look like once we remove it? Have we really impressioned both sides adequately? So you have to be mindful of that, because when you do remove it, you see that you may have some issues. You may have impingement of the tuberosity and the hamulus. The other thing is you don't have any sidewalls here to really compress the impression material onto the prepared tooth. So that can become an issue too. So keep in mind, if you're happy with the triple tray, some people like it, some labs hate it. So it's just up to you and your lab to decide if you're getting adequate fitting restorations based on that. So let's take a look at some of the various types of impression materials and delivery systems which we can evaluate as clinicians. There's a lot of companies out there producing impression materials. Some are inexpensive and maybe don't offer you too high quality, and then some are high quality. We're going to talk about some of the high quality materials that we have available for us in the marketplace, and I'll try to home in on what I use as an everyday clinical procedure. But when we talk about VPS materials, we have to keep in mind they are the most stable and accurate impression materials out in the marketplace right now. And there's different types out there. You can see they vary. You have different coloration. You have different set times. You have different flow of the light body, the ability for the light body to coat the prepared tooth structure, margin identification, impressions that are high value like bright yellows, whites, orange, are sometimes difficult to identify as far as the margin and how well that impression has been taken. You can see just from this quick photo, there's a lot of different colors out there. Some are kind of stimulating, but some are kind of hard to identify when it comes to the margins, and you get too much reflection. I prefer more the grays, the blues, the browns that allow you a little lower value and something which you can really easily identify the proper margin. You also have different delivery systems. You have unidose systems. This is our typical 50 milliliter Automix cartridge. Sometimes they're allowed to put on little injection tips, which are hard to use. You can imagine the back of the mouth with this large gun. We also have these straight nozzles, which these are maybe useful in the anterior. As soon as you get past the cuspid, you don't have the angulation to provide proper access. So they have their limitations, and I'll show you as we go through this what I prefer to use on a day-to-day basis. And let's take a look at what we really deem important when we talk about a vinyl poloxane material. As I mentioned, it's a really stable and very accurate material. And one thing we want to keep in mind is that the attributes of the VPS materials, the ability for good surface contact, the surfactant chemistry that goes into this for that material to go ahead and coat the natural tooth structure, the set of the material, the quick set, because when we talk about the 90% of our workload, which is 1 or 2 units, we want to have something which sets up quickly and is easily removed. That certainly will cut down the time and the anxiety for the patient. We have to have a heavy body which acts as a support mechanism, does not displace the light body cervical injected portion of it, has adequate working time and coordination being such that as soon as we're done with the use of the light body and the working time, the heavy body's there ready to go ahead and be inserted. The hydrophilic nature of impression material is made only through the proper chemistry and the production of the VPS, because generally speaking, it's inherently hydrophobic. But certain wetting factors which are included will allow much better contact on the dentinal surface, because dentin is about dentin includes about 60% collagen and water, so it's a very aqueous type of material. The color is crucial, as I mentioned, for adequate tissue for margin identification. Has to have high tear strength and complete recovery from deformation upon removal. Those are a lot of things to consider, and you'll see as we go through this that there are materials that offer all that and more, and something that you'll want to, if you're having problems with your impression materials or you're having issues with remake and things like that, this is going to allow you the opportunity to upgrade your clinical procedures. And let's put these things together here in another kind of format, looking at some of the features we have to keep in mind when we talk about taking impressions. One is, of course, in this type of case, we're going to make some final CAD/CAM restorations for this patient. She's a middle-aged lady who had extensive composite work done. I had done some pin-retained some composites for getting breakdown. Certainly the need with this type of situation to place our all-ceramic crowns. So as we survey this case, we have to think about, after we're done with the preparation, how best can we deliver the material, especially the light body. I do a single tray technique, light body and heavy body or tray body. I don't gouge it out and try to go ahead and take a secondary impression. All you need is one system, light and heavy body, which act together in proper tissue reduction. You're really in the best possible shape to go ahead and capture the fine details. So in this case, we have to think about delivery system of our materials. So when we're done, we have a really nice impression. And as I mentioned to you before, when you have multiple units fixed bridgework, it really behooves you to go ahead and construct a custom tray. You get even distribution, even shrinkage of the material. We don't have any problems of burn through, and easy margin identification, very exacting, accurate model. When we're done with that, as soon as we're done with the impression technique, at the same time, take a quick snap alginate. You can go ahead and pour that up in quick setting stone. And from our preoperative wax up, we can go ahead and make a putty stent, a VPS putty stent form. We can actually go ahead and produce our provisionals on a model if you don't want to do it intraoral, because there is some minor shrinkage. These are BIS acrylic resin, very hard, easily polished, very durable provisionals, which will allow us during the time of provisionalization, which may be anywhere from a week and a half to 2 weeks, allow us the stability to go ahead and maintain those teeth in the proper arch form. We're not going to have problems of interproximal migration, hypereruption, and these are all splinted together. And certainly from ease of removal and placement, that's one thing. But these being all tied together won't have a tendency to drift or create any issues from that standpoint. When we get our final CAD/CAM restorations back from the lab, we have to spend minimal time as far as adjusting the contacts and the occlusion. So keeping that as a backdrop, let's get into more specifics. Is how do we actually create tissue distension? For the most part, unless you're in a very unique situation, we're going to have some impingement on the soft tissue as we go through the preparation, as we go ahead and break the interproximal contact, as we go ahead and prepare below our existing restorations, our composites. More often than not, we're going to have some minor hemorrhaging we have to deal with. How can we displace tissue? What do we need to do to accomplish this, to get the opening of that crevice so we can get the soft tissue injected into that? We'll take a short glimpse into this by simply going ahead and looking at this one particular preparation on tooth number 13 and give you some insight in how this is done. You can see number 13's got a large composite. We can go ahead and replace this with a pressed ceramic crown. And I'm not going through the preparation, but I'm going to show you some of the available options that you have. And probably 90% of the cases that I do, I'm using some type of cord placement. Now, there are a lot of options available on the marketplace. You can have braided, you can non-braided or non-woven. You can have different widths, single, 0, 1, 2, 3. You can have epinephrine impregnated if you want, and you can also have some type of astringent. Now, I prefer the non-woven. These have no memory, and they really absorb our astringent, which is going to be Hemident. Hemident is aluminum chloride. It's the same thing that we use when we go ahead and put our eye drops in the morning. You wake up and your eyes are red, put a couple drops of Visine, and this astringent really reacts in the same way. That causes no systemic effect whatsoever. It's strictly local, and it causes vasoconstriction of the blood vessels, helps with hemostasis. There's no precipitate form. It's a very clean material as long as we don't have excessive amounts present, and it really allows us the shrinkage of the blood vessels and the tissue to help us get an opening in the clavicular area. And this is really what I utilize most of the time when it comes to taking impressions. We have our Hemident here, the aluminum chloride. We have our non-woven #2 ginger pack with epinephrine impregnated. We have some type of delivery system. I'll show you the one we're using now. We have some type of cotton cap, which I'll show you how that comes into play. And then we have some type of packing instrument. The best packing instrument that I've utilized, I'm not showing it here, it's a packing instrument from the Garrison Company in Michigan. It's just really a thin blade at different angles. Serrator really offers a lot from the standpoint of getting the tissue compressed down in the sulcus. So the first thing we can do, we've already done our preparation. I'm going through all that. We have our rounded shoulder preparation. All our internal line angles are round, no sharp internal line angles. We have a smooth axial surface, so we're ready to take the impression. In this case, we had minimal or no bleeding. We're able to take the #2 cord, which has been soaked in the Hemident, place it in the sulcus for 2 minutes. You can see once we twist this tight and compress in the sulcus, there's always a tendency for some of the excess Hemident to extrude. And one way we accomplish the removal of that is to place on this cotton cap. Now, this really absorbs all the residual Hemident, any sulcular fluid, maybe some minor hemorrhaging, and really offers us a clean feel because we don't want to take this impression with an excess amount of material present, because it will have a tendency to create perhaps some issues when it comes to the set of the VPS material. So we're better off to go ahead and have a clean, dry field like I talked about before. And that's the axiom that you see here on the screen. You must have a clean, dry field. That means no bleeding present, no hemorrhaging, no saliva. You want to have adequate tissue retraction. That can take on many forms. You may have a very deep preparation where you're down the attachment. You may have very superficial. So you have to kind of focus on where you're at with your preparation and what you need to accomplish as far as tissue retraction. We'll see later on when we get into deeper preparation, simply the cord may not allow us enough lateral distension. We may have to use some type of soft tissue laser or electrosurgery, the case may be. But now once we remove that cord gently, we don't want to just rip it out. They usually stay moist. We're not going to tear the sulcular epithelium. But if you have any residual material left there, any debris left, you want to clean up, simply rinse it, air dry it real quickly with your triplex. Then we're going to take our impression material, light body impression material. We're going to start in one fluid motion, inject this into that open clavicular area, and follow that around in one smooth motion, one unified bolus of material. That's the most critical time to get that in the sulcus when that tissue is at maximum distension. Because after about 30 seconds or so, the elastorin fibrils, which you have distended through the compression of that cord in there, will start to relapse and start to collapse. So we want to get our material into that sulcus first to support it as it goes through that collapse process and allow the support of that sulcus. So that's important that we have that, and we want to allow at least 0.3 of a millimeter extension beyond our margin, have at least 0.3 of a millimeter width to that sulcus being open to get the proper amount and strength of material into that area. Because when we're done with the material, we have a really nice model to deal with, and that is one of the real advantages of the VPS material, because it allows the technician to pour and re-pour these, and they have a solid stone model. They can try things in to check the occlusion, margin, interproximal contact, and it really aids us when it comes to the final case. Less time in frenzy and frustration at the delivery appointment. So when we get it back, we have this absolute impeccable fit. And I'm showing the margin right here. We're getting these marginal fits down to 75 microns or less. And you think about that, what 75 microns is. 75 microns is the brand new tip or sharp tip of a brand new Explorer. And it's incredible. You can barely detect the interface between the artificial crown and the natural tooth structure. Just enough for cement space, and it's really incredible what can be produced if you send the proper impression, do the proper preparation. You have a good technician to go ahead and capitalize on that. And this SEM just identifies what we're talking about. 50 microns is about the width of a human hair, so we're getting down to infinitesimal types of dimensions there, which are really sought after, but we can achieve that, and something we aim for time and time again. But as we go through this, let's kind of put this together in a little bit more of a comprehensive approach. By that, I want to go ahead and tie this together from a standpoint of kind of looking at this case, talking about tissue distension, injection technique, how we go ahead and propose that, how that's accomplished, and what we can do to go ahead and do this time and time again. And I'll talk about the impression material that I'm utilizing now and what are the benefits and attributes of this material. In this case, we have a young lady in her mid-40s that we're going to go ahead and we want to go ahead. We're going to be placing crowns on teeth number 3. You'll see there we're doing CAD/CAM restorations, and tooth number that's tooth number 3. We're doing tooth 3 and 30. Let me go back to that just to show that again. We're putting crowns on tooth number 3 and number 30. Tooth number 3, once we look from the occlusal, she had minor symptoms from cold, recurrent caries, breakdown, micro leakage of the amalgam. We know we're replacing that with some type of base, and we want to go ahead and I'll show you how that's accomplished. Once we do our preparation, I won't get into all the minor details of that, but we've replaced this base or the amalgam. This base is Vitrobond Plus, RGI type of base, light cured, wonderful, really decreases any potential symptoms down the road. So now we've done our preparation. Our tissue is free from contact on the prepared tooth. Now we're able to go ahead and take this. This is a disposable syringe from 3M, which has really offered us a lot of advantages. I showed you the other one that we used before with the aluminum tip. This can be cocked to a 45-degree angle. This plunger is pulled out in these portals. You take your Automix cartridge and snub that up against there. You reinsert the plungers, and then this is mixed in this small little portion. So you save a lot of material. And this is cocked about 45-degree angle. You have this small little orifice that you now can go ahead and get that tip right into the sulcus. As I mentioned, we'll show that more graphically as we go along. But once you get that tissue distended and sulcus open, it's just inviting, waiting for that material to be injected. You don't need to keep a cord there. You want to have the maximum amount of space for that material to be injected in there and to support the proper heavy body. This is imprint 4. It's really meant for 1 or 2 crowns. It's a 35-second working time, a minute 15 set time. So under 2 minutes, you have the case in and out. And that, believe me, we all know that less time you have to keep that in there and keep it stabilized. And same thing for the patient. Get back on the second molar really makes it a lot easier to handle. It's a thermoreactive material. It's hydrophilic because of the surfactant chemistry included in that. It's got great flow. That's one thing about this light bar. It really flows. It coalesces. You don't see any problems of stacking and things like that. And it really is it's got a nice color too, which will allow you proper definition when it comes to reading that. We're going to use an Automix system for our heavy body. And the heavy body is the yellow that you see here. It's a nice material because it's kind of a fluffy material, but sets up rock hard after the minute and 15 seconds. So you have plenty of working time to go ahead and inject your light body over 1 or 2 teeth, and this heavy body just supports it, and practically complete recovery from deformation once you remove it, your snap removal. So it really is a nice material to work with. Nothing is left behind, no residual, a very clean process. And speaking of then making our provisionals, which I alluded to before the patient comes in, before you start preparation, we always take pre-op impressions, whether they're quarter arch or whether they're half arch anteriors. These will allow you to convey information to the technician, such as morphology, occlusal scheme. We also do an opposing model. I don't even use algae anymore other than just for study models. When it comes to crown and bridge, and especially CAD-CAM cases, we want to have really dense, really firm, accurate models. We always use a VPS type of material. It certainly aids us. We don't have to pour it up right away like position penna, and allow us to go ahead and pour it up later. Maybe it's 4:30 at night, people want to get home, everybody's tired. Take your impression, it's stable for a long period of time. So we're going to go ahead, in this case, we're using our bisacrylic resin material from our pre-op mold. We're going to go ahead and then insert that in the mouth. After 4 minutes, you have this very well orchestrated fashioned provisional. You have the proper occlusal morphology, the proper occlusal contact, both interproximal and opposing dentition, which matches the original contours of the prepared tooth. So this really is a quick way of stabilizing the case because of the density of the material, because of the fact that it is wear resistant, polishes up well. The patient will maintain good hygiene. You'll have a good tissue reaction over that period of time, and really allows less seeding, less frenzy, less seeding time when it comes to the final impression. In this case now, we get our crown back from the lab. This happens to be a lava crown. There's many different crowns on the market, Bruxier, Procera, but this is a zirconia oxide-based system. It's a polycrystalline mineral oxide. It's got a flexural strength of 1,200 megapascals. Extremely hard, very dense material, very wear compatible, fracture resistant. It's these systems, and there's warranties or anything go with them. You look at various studies. The CAD-CAM restorations or all ceramic press restorations really have a better track record than our traditional porcelain fused to metal as far as success rate. And obviously they're very aesthetic. But you can see the sharp margination that I'm able to create from the impression because of the CAD-CAM, computer-aided design, computer-aided manufacture, or milled. We have an internal coping which is milled, shaded, and then I like to veneer these. I like to layer on top of these copings to go ahead and give a nice natural end result. You can make these in monolithic form like the Bruxier. Lava Plus will allow you just one monolithic mass of zirconia if you don't want to go through the layering technique and aesthetics aren't of a critical dimension. This certainly will allow you a very strong restoration, which you can cement with your conventional RGI cements or your SEC cements. But you can see on this, and this is how I articulate. I take stone-to-stone models, I hand articulate them, I'll have a bite ridge on this prepared tooth, and now I have the margins I've already defined and marked, send that to the lab. When it comes back, everything should go in without too much frenzy, without too much frustration. So as we put it into place, we have to think, what are we going to go ahead and cement this with? And there's different materials we can use when we talk about cementing. And when I mentioned to you before, when you have a core-based system, you can use your RGI types of cement without a doubt. I like to use these self-etch resin cements for various reasons because they're really the workhorse, the universal cement that we can use in almost every case other than veneers. For posts, for metal crowns, porcelain fused to metal crowns, all ceramic crowns, etched ceramic crowns once it's silanated. You get high bond strength to all the tooth material, to all the tooth structure, the dentin, the enamel, well over 20 megapascals, to all the metals, the non-metals, the ceramic, and certainly allow us a lot better opportunity for good bond strength. You get micro and chemical bonding to the calcium and the dentin. Yes, fluoride releasing, dual cured, shaded. What more do you want? It's a methaculated phosphoric ester and glass fillers, and allow a conventional set 5 minutes, or you can also light cure it, which really has some benefits. We use this for post, we use this for everything, and it really is a workhorse when it comes to, it has 4 or 5 different shades. There's many competitors that offer something, that type of description. But we're going to go ahead and place this in the crown. Now, if it's a core-based crown like zirconia, you do not silanate it. That's only for etched ceramics like Emax where they're pressed or milled. We're going to go ahead and layer this in. You don't need to fill this up to the top. You simply want to layer this in. It's only like 20-25 micron film thickness. Cover the margin, and then when you place it in, you're simply going to toggle it back and forth. Very easily, the excess cement is expelled. Run through your floss, hold it in place. Clean up the excess. I just clean up with a cotton roll. That's all you need to do. I don't let it go to a gel stage and try to pick it off. It removes very easily. Then we're going to go ahead and light cure it. The reason why we light cure it with our LED, which has about 1,200 milliwatts of energy, you'll probably get another maybe up to 10% conversion of that polymer, the cement polymer, a little stronger polymer form when we can introduce the light into that. And anytime I have an all-ceramic restoration, I'll do that time and time again, whether it be zirconia, pressed ceramics, and it just really, and you get a really good hard firm set right away, not having to wait just for the cold cure to go through the typical polymer formation phase. So we use that, and then we're going to go ahead, once that is placed and cemented, we're going to go down to tooth number 30. You see here, it's got a large composite, no history of any symptoms. It looks like it was well bonded. There's no sense of any staining, any micro leakage. So that's going to allow us, the opportunity to probably keep this in place. Unless there's indication there's issues, don't get involved with removal and perhaps creating issues with pulpal reaction to placing some type of different base or any type of adhesive in there. Leave well enough alone. Just deal with it as an intact basis. You can see once we remove the interproximal contact, we have some hemorrhaging. Usually we hit the interdental papilla. When you have something like this where you have limited oozing, it's not of great depth, you can simply take this number 2 cord. It's saturated completely with that hemodent. Leave it in there for 2 minutes. You'll find out once that's done, you can lift that off, rinse that off, and you'll have now you'll have initial displacement of the tissue, distension. Now you can take your secondary cord, and this is the same cord. It's the number 2 cord, the non-woven Gingipack, that we go ahead and we tightly twist and blot out the excess. We're going to place that in for another minute or so. We're going to put on this Compra cap, which once again what that does is allows the absorption of the extra fluid into that cap during that process while it's in place. And usually once you remove the cord, you'll find out that you have a clean, dry feel. There's no residue left there. Now it's just waiting, inviting for that light body to be injected into the subcellular areas. And that's our final impression. You can see the density of that, well-defined margin, well beyond the margin with our rounded chamfer with our rounded shoulder preparation, and allows us the security of knowing that we've really captured everything we need and then some, and then just the final lava crown in place. So a really nice way, you can see the nice marginal fit, a nice way of handling these situations, which is the workhorse of our clinical procedures, for our clinical cases. There's other ways too we can gain some tissue retraction, some relaxation, just depending on what the nature of the preparation is as far as the depth. This is a aluminum chloride paste or clay material. If you have margins which are just slightly subgingival, this does a good job of getting some relaxation, some shrinkage. It'll also help decrease some of the potential hemorrhaging if there's anything there. And this is left in for 2 minutes. And once it's left in there, you go ahead and you can rinse and dry it. And it does a really good job when you have those types of conditions present. When you get deeper preparations, that's where you have to consider placement of the cords. But the aluminum chloride itself as a chemical does a good job in those kinds of cases and really allow you to go ahead and have freedom of not having to place the cord. And then we're going to go ahead, and this is what I mentioned before, is injecting this light body, make a complete you'll allow us, once we inject that light body all around there in one peripheral movement, now we've injected that material in the sulcus, and we're good to go. We have one bolus of material. We can coat the axial surface and also the occlusal surfaces, and now we can go ahead and complete our impression. You can see the density and clarity of that, and when you pour up the stone, look how that replication surfaces there. I've talked with some of my dental technicians regarding this, and they say you cannot beat a better accurate stone model of VPS as far as the digital scan of this. It's just really incredible how accurate and detailed this is versus anything else they can deal with. And this is then sent to the lab. Now they go through the fabrication process. They outline both the morphology and the construction of the form of that occlusal form, and also the margination. So having that distinct margin is really key and critical to the exact margination that we deem important for the outcome of the case. And when you get it back, I displace that tissue. This is once again a lava crown, CAD-CAM zirconia oxide layered, veneered. Look at that nice marginal fit. Because of what we offer to the technician, having a competent technician that knows what they're doing, and you get the precision because of all those factors coming together. We also have the need in situations to go ahead and deal with multiple preparations. This is an imprint, the regular set, which will allow us in multiple preparations, maybe a minute of working time. So if we have bridge work, we're doing multiple preparations, allow us longer working time. So we have enough time before the working time is up to complete the procedure and end up with really nice impression, more ease, no rush, and plenty of time. And then we have these well-fitted pressed ceramic crowns that we place, and absolute wonderful marginal fit from those. We also have to keep in mind as we get into some of the other issues here that can come into play is the use of tissue retraction when the conventional cords or gingival paste really is not apropos because of the depth. In this type of situation, when we're placing post-in cores or pin cores, we need to have at least 3 millimeters of natural tooth to support the post-in core, the ferrule effect. We need to get a little bit deeper, and we're probably 90% of the time right now using fiber posts for doing this. But just to show you this and what we're going to be utilizing, we're going to be using this soft tissue diode laser. We use the 2 watt. The patient is anesthetized. It's only an end cutting instrument, and I'll show you that the fiber. It's not as quick as using electrosurge. It takes more time. It's less traumatic, does less tissue damage, less bleeding, and less potential recession. So when you come to anterior cases, that can be critical. But you can see this. We've already done our post-in core. We've done our initial preparation. Now we're going to go ahead. We're going to trough around, especially the interdental papillary, get at least 2 to 3 millimeters below that to support the post-in core. So we take this. You can see this, the tip from the diode laser, and this is a disposable tip. You can bend it. It's a one-time use. You put it in your sharps, and it's really a sharp precision instrument. It only cuts at the end, though. You'll see the energy release from the laser only cuts into that follicular epithelium from the very tip. It does a nice job of reducing the follicular epithelium. Now we have all sorts of access to our margin. We can go ahead and take our material, inject it around there, and then we have a really nice well-fitted pressed ceramic crowns we put on. You can see right after being cemented, and the tissue response is really favorable. We also have cases where we may want to use electrosurge. I really don't use the electrosurge as much anymore, and I'll tell you the rationale. Once I got hooked on the soft tissue diode laser, which is really an easy instrument to use. They're inexpensive now. You can get them under $2,500. They really allow you things you can do that you couldn't do with the electrosurge. Electrosurge, patient had to put a ground in their back. Every once, because you get some arcing between the metal, they get a little spark that flies. They feel it. They kind of jump out of the chair a little bit. So that kind of wakes you up. But you can't use it around metal or metal crowns, amalgam, implants because of the transfer of the energy with the metal. It's a more of a destructive wavelength because it goes to a deeper cellular level. It cuts much quicker, because it is, and this is what we're using. You can see this is tip, and this is only sterilized. It's not a disposable tip. You can get it on, put it on cut or coag. But you can see this tip right here. It cuts laterally, so not only cuts on the end, but it cuts laterally. So if you really want to open up the sulcus in a quick manner, that will do it. As we look down this, you can see the tooth was vital. I put in some pins, some Coltine pins. We're going to do a build up. They normally do a endo, but patient didn't want to go through the time and expense, and to use this was really a time saving for her. But anytime you use that electrosurge, there's usually increased bleeding and potential for increased recession down the road. You may have to wait for a month, take your impression. And the other thing, which is potentially an issue, is there's a sense of burning flesh. So, I mean, that can be a problem. You obviously use the high speed of act, but even so, it can become an issue. And that's a final placement of our this happens to be a Procera lava crown or Procera zirconium crown. So you can end up with a nice tissue response, but it just takes a lot longer to go ahead and get through that process, and it takes longer for the inflammation to clear up. Let's see. I want to get to a few questions here because it's great talking with colleagues from around the world. It's amazing if you see the people that sign up here. What would it'd be nice. Hopefully everybody understands English and everything, and they're willing to go through all this. I appreciate the opportunity to be with everybody from around where you get people from Europe and Asia and you name it, Middle East and Canada and South America, the U.S. It's just great to be part of this opportunity to work with colleagues from around the world. We're going to answer a few questions here. I'm trying to get through some of these and make sure I know what they are. One question asked was, do you always remove your cord before the light body is delivered? Yes. This is a single cord technique. I do not keep a small cord in there. The reason being is that you really want to maximize the influx of that material into the sulcus, and you don't need to have that cord to interrupt that process. I want to get as deep into that sulcus as I can, and once the coordination is really important. The coordination is really important because once we place the cord in and we're ready to take the impression, the assistant will inject the light body into the injection syringe. And as soon as I get that in my hand, I gently remove the cord, and now I'm at maximum distension, and I simply go ahead and do the injection of that. And that's all. You don't need to have a cord in there. And the cord bonds to the impression material. It just becomes an issue. I'd rather have as much in there as I can from a standpoint of getting the material in there and getting as maximum amount of material in there. One question here was how often you use Emax press crowns and where to use them. I use Emax lithium disilicate crowns from usually premolar to premolar where aesthetics are premium, and I'll tell you, probably 90% of the time I'll do some veneering. We'll make some type of coping that they can cut back and layer in some incisal. To me, they're probably the most incredibly looking aesthetic. They're 400 megapascals of strength. You can bond those. They're etched silica. After you silinate them, they offer the strength. The fit is incredible, and they offer the appearance of the translucency. So anytime in the anterior, that's always my number one go-to, especially when you're trying to match one to the other. It becomes it's a daunting task. That's where we get involved with the use of the 3D shade guides, and we also get involved with the use of the and digital photography, which is incredible. So, and all that information is certainly something to be discussed. Let's see, there's someone that asked about digital impressions. I've done some digital impressions. I'll make sure I get the right question here. Do you take digital impressions? If so, for what system, for what restoration? I would hate to categorically say that digital impressions are my first choice when it comes to taking impressions. And here's the rationale for it, and for what my reasoning is behind it. And I want to make sure that I give you my contact information. It happens to be Northern Michigan. If you have a chance to come to Michigan, you'd like the lakes, just about that time to get ready for snow skiing. Do you take digital impressions? If so, what system do you prefer? What system? What restorations? From my standpoint, you can take a high quality VPS material or VPS impression, any tooth, any preparation, subgingival, supragingival, anywhere in the mouth without any questions asked. When it comes to scanning, you have to keep in mind the challenge of getting the scanner in there. Sometimes you have to use powder, sometimes not. Some of these are rather large and kind of bulky to deal with. You have to have margins which are easily identified, and you also have to have enough time to do it. There's the learning curve, the cost. You're not going to get, put it this way, you're not going to get a better fitted crown by using a digital impression, nor will doing digital impressions make it any easier to the conquest of getting accurate impressions. You still will have to go ahead and have tissue retraction. As I mentioned, you may or may not have to have the titanium oxide spray. You're going to have certainly not only tissue retraction, you have to have no hemorrhaging, no salivary contamination, and it certainly becomes a challenge from that standpoint. I think it's kind of neat from the standpoint of you can convey your information quickly to the lab. They can get started on the case as far as design digital with that digital information, the STL file. They can get creative in that. You may or may not have a model made, just depending. I was talking with one of the large labs. Some labs just send the crown back to the clinician. I prefer to have a model, look at the margins, the occlusion, the interproximal contact, the morphology. But then there's a cost, of having that made and acquisition of all that. So it becomes kind of an issue from the standpoint of filling all those criteria. Not that it's going to displace what we're doing now, because I mentioned I don't think it will, but it'll certainly allow you a quicker opportunity to get the crowns made if you're doing your in-house milling, if you're doing your own milling, whether it be a wet mill or a dry mill. That'll certainly enable you to get started on that case right away. It does have some drawbacks. What you can mill in the office, you can't do zirconia, you can't do any layering, things like that of your like your Emax crowns. But for some people, it certainly offers a lot of opportunity, and certainly the technology is here. There's no question about that. Just whether or not you want to spend the time and whether or not you feel it's going to improve your dentistry. And that's what I think you have to look at. And there's a lot of scanners out in the market, and certainly it's worth looking into. And just depending what your level of interest is and what type of dentistry you're doing as far as crowns and bridges, and whether it'll pay for itself and everything else. There's another question. Do you use two chords technique? And that's kind of what I was recommending before. Is one of the issues that have been out there is that the use of two chords, where you put a small number 0 or number 1 chord, leave it in the, do that before you do your preparation, leave it in, put secondary chord in, remove that, and keep the primary chord in there while you do the impression. I guess that has some merit. I've never done it that way. My recommendation is that I like to prepare to the free gingival margin. At least I know where I'm at. Put a chord in maybe for 30 seconds to get minor distension if I have to lower the margin down below the free gingival margin. But then I want to go ahead and put the largest size chord, one single chord, to maximize the width of that distension when I place that chord in. And to me, I don't want to leave another chord in, or all it does is, potentially bond to the impression material and create problems. I want to just maximize on that sulcular extension and get that bolus of material injected as far as I can subsulcular. That means having a chord of maximum width to use that. That's why I like to use the number 2 chord, because I'm going to get well over 0.5 millimeter of width to that distension. And to me, that really offers a lot when it comes to having a wide area to get that tip in there. Then you have a small tip like that, and you're able to go ahead. And deliver that light body, and just have a wonderful amount, incredible amount of material you've injected into that sulcus. And to me, it really offers the maximum use of that system. You have to have the right type of light body. You have to have the supporting heavy body, and you have to also have some type of tip or injection tip that you can go ahead and get that material delivered in there. It's not going to flow in there magically, but if you can get that tip into that open sulcus, you got it made. And to me, that really simplifies the whole process. Before I close here, and I just want to make some final comments. It's been a pleasure to deal with everybody tonight. My contact information there is up on the screen for you to go ahead and contact me at any point in time regarding anything from adhesives through impressions through ceramics. We've done a lot of work on that in seminars and dealing with all sorts of different restorative issues, and it's a pleasure to be here tonight. And once again, I extend my appreciation to 3MSB for being partnered with us on this presentation, and I hope it's been worthwhile to you. I want to thank you for attending this class. I hope it was worthwhile for you in your practice. My goal was to address issues we face every day and to help your clinical dentistry be more predictable and more successful. Please keep in touch if there's anything else I can do for you. If you have any questions, it's always a pleasure to interact with people from around the world. That's why I had that globe there. It's a small world. It's nice that we can get together and discuss things and benefit from it. So enjoy the rest of the week and the evening, and have a good rest of the week, and stay warm, and thank you, and